Greetings. My name is Dr. Sarah Chavez, and I am the Senior Research Scientist for Siteman Cancer Center's Program for the Elimination of Cancer Disparities, also known as PCAD. And today I welcome you to this webinar, Breaking the Bank, the Financial Burdens of Survivorship. The purpose of this webinar event is to educate our cancer patients and survivors on the impact of financial burden in terms of cost, care, and treatment. This webinar event will focus on the adverse effects of financial burdens in regard to the decisions on treatment options. The webinar will also focus on how hospital systems are attempting to manage the cost, care, and focus on the resources that are available to the patients and survivors in regard to financial burdens. For those of you who are joining, we will have a pre-test displayed on the screen. The test is designed to assess your baseline knowledge on the different topics that will be discussed in this webinar. And a post-test will also be given to assess your knowledge after the panel's presentations. So okay, while everyone is logging in and joining us, we thank you for completing the pre-survey question, which should be appearing on your screen now. Okay, the presentations today will go as follows. First, we have Dr. Mark Fiala in the Division of Oncology, who is an assistant professor. We have Ms. Julie Richardson, who is a clinical social worker in our Department of Oncology, and Lori Lewis in Siteman Cancer Center's Department of Billing and Reimbursement. So first, I would like to introduce Dr. Mark Fiala.
Hi, thank you, Sarah, for introducing me. It's a pleasure to be speaking today on this panel. So as everyone on this call is probably aware of the financial burden of cancer. And today I'm going to talk about financial toxicity and how that intersects with that and how that's slightly different. So like I said, most of you probably understand just the cost of care of treating cancer. Many of you probably have faced this firsthand. For example, my mom had late stage ovarian cancer when I was just a teenager. And although she was thankfully cured of her cancer, the debt that she incurred from her treatment lasted several decades past her being labeled as cured. And, so we experienced this firsthand in my life as well. And that's why this is an important issue to me. And it's well known that the cost of cancer is quite a burden. In fact, when you ask people what worries them the most about getting the potential of getting cancer, financial burden is the most cited worry, even more so than things like dying, pain and suffering, or side effects of treatment. And when you talk to people who have had cancer and cancer survivors, over half of them say that they were unprepared for the expectations of the cost of care and unprepared for their ability to pay for their treatment. And asking patients and people with cancer about how they're concerned over their ability to pay, we see that the majority of people say that they are very or somewhat concerned with their ability to pay for their care, and only a small proportion are not. But like I said, the cost of care, as can be alluded from here, doesn't necessarily affect people similarly. And that's why the field of research is really moving away from the idea of financial burden and more into financial toxicity. So while financial burden is the cost of care, financial toxicity is really about how those costs affect you on an emotional level. So the textbook definition of financial toxicity is a negative outcome that results from objective financial burden and perceived subjective financial distress. And really, that's just a fancy way of saying that the cost of care is the objective financial burden, but really it's the distress that it causes somebody that is this idea of what we call financial toxicity, which is what we're most interested with today. And really, like I said, the field has shifted that way for two reasons. Number one, the burden of care doesn't affect everybody the same, meaning while no one welcomes a copay of, say, $100 or more a month for their treatment, that obviously would impact somebody less who has more financial means than somebody with more limited financial means. For some, it might just be the difference of taking an extra vacation that year or scaling back in other ways. And for some, it might be choosing between your medication and whether or not you're paying your bills. But also within an individual person, the bills might mean different things. So, for example, if you have if you need a car repair and you're expecting a large bill and it's only, say, a couple $100, you might be like, okay, it could be a lot worse. You might not be bothered by that bill. But for example, if I get double charged for my $4 box of Cheerios at the supermarket, I am furious. So like I said, it's not necessarily just the cost of care, the cost of the bills, but how that impacts you individually that plays a role with how it might impact your care. And what we see is that among people with financial toxicity, I said there is varying ways that it affects people's life. So the majority of people do have to cut back on leisure activities, and about half do have to reduce spending on things like food and clothing, less discretionary things. Um, Again, about half have to use savings to help cover their out-of-pocket expenses. But then we see about a fourth of people have to avoid filling the prescriptions, or take less medication than prescribed, or partially fill a prescription. And obviously, this could impact somebody's well-being if they're not taking the medication as prescribed. And just some quotes from people who are living this. So as one patient told the researcher, I can't pay that. I cannot. That's a third of our income. I can't do that. So I would have to do without my medicine. Or as a patient told me, when thinking about what would happen if they had to pay for their medication, they said, I'd be in bad shape. I mean, I'd have to stop taking everything because I couldn't. That's over $200,000 now for what I got the other day. Or as another patient told me, 30 pills cost me $16,000. So how would people be able to afford that if they didn't have good insurance? I just don't know. It would be awful. And highlighting this impact of how treatment might impact decision making, I recently did a study where patients were asked if they were given a copay of either $100 or $25 a month, what kind of changes would they make related to their care? And what we can see is that like 70% of patients were willing to make some kind of trade-off with their care. So most commonly, patients were willing to take an injection versus a pill. So over half of people were willing to do that to reduce their copay. About a half were also willing to take worse side effects to reduce their copay by that amount. And then what we see is about a quarter of people were willing to take worse outcomes. So the way it was described in this study was 6 months less of progression-free survival. So ultimately, they were choosing a less effective medication to try to reduce their copay. Now, these were all hypothetical treatment scenarios that patients were in, but these mirror real life decisions that people have to make when they're undergoing their treatment. And obviously, this financial toxicity can have an impact on your quality of life. So first off, if you're choosing less effective medications or medications with worse side effects, it could affect things like your symptoms or your overall health. If you're not taking your medication as prescribed, that could also increase your symptoms and decrease your overall health. And in the end, all of these avenues are intertwined. And when one thing gets affected, it could affect the rest of your quality of life as well. So it's important to be cognizant of how these decisions might be impacting you. Now, there's been a lot of research over the past several years about who is at risk for financial toxicity, much more than I have time to discuss here today. In a nutshell, everyone seems to be at risk. There are certainly factors that put people at higher risk of experiencing financial toxicity than others. So if you have more limited financial means before you have cancer, it sets you up to have a higher likelihood of having financial toxicity once you have cancer. Also, people who are younger, still in the workforce, are more likely to experience financial toxicity. And that's because not only are they paying for their care, they might also lose income because they're having to take time off of work or even leave the workforce so that they can receive their cancer care. I said, in a nutshell, like I said, those are certainly things that might increase your risk, but this should be something that everybody should be on the alert for, even if those aren't a factor for you. So the question is how to cope with financial toxicity. And certainly Julie and Lori are going to give you more details on a person level of things that might help. But in a nutshell, what the research shows is the most basic thing is we need to make sure we're talking about the cost of care more in our interactions with providers. So only about a third of people report discussing the cost of their care with their providers. And of those that do, about half report reductions in their costs. So by talking to your doctor about concerns for costs, they might be able to refer you to financial assistance, to people like Julie and Lori who might be able to find you help. They might be able to appeal to your insurance to reduce your copays or deductibles. It's potential that they could switch you to less expensive medications or change your tests or decrease the frequency of those tests or decrease your frequency of your visits with them if that is okay for your care and would be a way of limiting the costs and financial burden to you. And I hate to put the onus on each person, but it really seems to be up to each person to bring this concern to their provider. And it's because it's really hard for us to anticipate who is going to experience these problems. And part of it's because each patient and each person has their own unique financial situation, but also because insurance is so complex and all the intricacies that it's really unclear to providers what things are even going to cost when they prescribe it. And like I said, it could all impact people differently. For example, a patient I recently talked to was doing very well at paying for their care as far as their medication goes, but their biggest concern was every time they saw their provider, she ordered the standard battery of tests that she would for somebody with that cancer. Well, that was costing the patient about $300 every time they saw the provider just in lab fees because their insurance specifically had a high copay for labs. So they were able to talk to the provider, and the provider limited the number of tests she was doing to just the ones that were important for her care. And it reduced her costs substantially. Now, for some people, the labs are not your cost of concern or your area of concern as far as costs go. It might be the medications. So that just pinpoints that how different each person's unique experience with financial burden may be, and really why it puts the patient in the driver's seat to bringing attention to people like your provider, to Julie or Lori, to try to get you the help that you need to take care of the financial burden without developing financial toxicity. And that ends my part of the presentation, and I'm happy to answer any questions when we have time.
Hey, thank you so much, Mark. So next we are going to hear from Miss Julie Richardson. She is an oncology social worker at Siteman Cancer Center.
Thank you so much for letting me talk with you guys today. Mark gave some really good information, and I'm going to piggyback on his discussion. Today, I'm going to briefly talk about your medical debt. Now what do you do? How do you navigate your insurance? What about the prescription drug coverage? And if I'm returning to work, what do I do? When I do have to return. I don't know. Can you guys see my slides? Okay. Some of the things with the medical debt, talk to your healthcare team. That's going to be your most important thing. The social worker, financial advisors within your facility, explore the hospital-based financial programs that are there. The social workers definitely can help you figure out what is out there within Washington University, Siteman Cancer Center, BJC, things like that. We'll help you explore the financial aid programs, and we'll help you get through some of those. One of the important things, talk to your creditors. Let them know what you're going through. Some creditors are more apt to work with you if they know what's going on. They may have you just pay for your interest instead of having to pay $40, $50, $60, $80 a month, or $100 a month, or not paying at all. It may not hurt your credit rating quite as bad. So that's going to be really important. Find out what your community resources are, in the community. When we talk about insurance, especially, Mark did a good job about just talking about copays. Some things you want to look at is how do I get the insurance? And there's 3 different ways. You can get it either through your employer, through the marketplace from the Affordable Care Act. The nice thing about that is it was created for individuals to shop for and to purchase health insurance. You cannot be denied, or your rates cannot be increased because you have cancer. So that's the nice thing about the marketplace. And then the third place to get insurance is obviously through the government, which is through Social Security disability if you're 65 or older, or if you've been disabled and collecting disability for 2 years. The last one is Medicaid. That's a state-run program, and that's obviously based on your income. Mark did a good job about explaining copays. That's something that you might want to consider is, are my payments going to be higher up front with less copay, or is it going to be lower with a more copay? And a perfect example, if you're going to the doctor 3 times a week, your doctor visit may be $20 per copay, but your specialist visit may be $50 a copay. And if you have to go to that specialist 3 times a week, that's $150 right off the top. That, most people want their copay when you first walk in the door. So right there, you're looking at $150 a week, just in copay. That doesn't include any of your other insurance that you're dealing with. And so make sure that the insurance is right for you. Make sure you talk with your employers. Most employers have, during open enrollment, they have a lot of programs that you can watch and that you can review for, to make sure that you're getting the right insurance information. Talk with financial advisors, or there's insurance navigators. I know Washington University has insurance navigators that can help, make sure that you get the right plans. There's programs out in the community, through the Department on Aging to make sure that you're getting the right prescription coverage. So that's really important. And prescription drug coverage, Mark hit the nail on the head when he said, some people, they have to forego some medications, and, they have to, maybe not eat out as much, or, eat something a little less than what they would like to. One of the things with prescriptions, there are a lot of copay assistance programs. If you have commercial insurance, you can, possibly get a copay card. A lot of cancer medications, their copays, it's not uncommon for me to get a note from somebody that says, hey, their copay is $2,400. What can you do? Are there any resources out there for that? The best thing we can do is we look for copay foundation assistance. If there's no copay assistance, then we go through the manufacturer. A lot of manufacturers are really good about giving assistance, for some free medication. However, the caveat to that is that the foundations are normally income-based. So it's not an automatic that you're accepted once we apply for the medication. I had a patient that was denied service because they were over income by $7 and their copay was over $4,000 a month. And they missed the cutoff by $7. And the manufacturers are like, sorry, there's nothing we can do about that. So then we go to the doctor and we say, okay, what can we do? How can we help alleviate some of the stress on the family, because they can't afford a $3,000 copay. So talking to your doctor, talking to your healthcare providers, that's real important when it comes to medication, because we can't guarantee that you can get the medication for free, or even at a discounted rate. We do everything that we can, but there's no guarantee that we're going to be able to find you coverage, especially this time of year when a lot of the foundations are out of money. So we have to be real creative in how we can try to find some funds. One of the biggest things is returning to work. And this is where the bulk of this presentation is that, you finished up your treatments or you're in the middle of your treatments and you want to get, you want to return to work. You're trying to feel a little bit better, but, you still have some obstacles. So what do you do? How am I able to return back to work? One of the biggest things, ease back into your routine. Don't just jump into it, expecting that everything's going to be perfect like it was when you first got your cancer diagnosis. Get used to your workplace setting. It's going to bring a lot of mixed emotions. Many worry about how other people are going to perceive them when they come back. Are they going to be able to do the job? And so you are going to feel very anxious, may, feel awkward asking questions, because you don't know what people's perceptions are going to be because you had so much time off. Share with what you feel comfortable with. If you're a very private person, you don't have to tell anybody what was going on. But, if you wanted to share with people, they'll understand. They may get a better idea. Check with yourself. If you're struggling, find yourself a counselor. Seek out a support group. Find out, can I really go back full time, or is part-time the best way, for me to go right now? How's my medication going to affect the way that I work? Am I going to be able to stay awake for a meeting? Do I have to alter my medications, just so I can, work during the day? Talk to your supervisor and to your human resources department to see if there's any special accommodations you need. Special accommodations is a very important thing. The American Disability Act of 1990, that was designed mainly for people that, do have certain disabilities, that have a physical or mental impairment, where it limits you. And when we think of special accommodations, we normally think of wheelchair ramps, wider doors, bigger bathrooms, the handlebars in the bathrooms, but that's not always necessarily the case. Special accommodations could be something as little as moving your office space from a little further to the cafeteria because the smells bother you. having something closer to the bathroom. If you have to go to the bathroom more frequently. The American Disabilities Act is really good about protecting people, that are eligible from cancer and from discrimination in the workplace. It does require employees to make reasonable accommodations, so that you can properly function in your job. And it does ensure that all employers treat you equally. And, the reasonable accommodations, it can be helpful, whether you're working through your treatment, going back to work after full time, or you're still experiencing some post, treatments. It is reasonable that, talk to your supervisor, so you can learn a little bit more of what your accommodations may be used for. Can I work the same hours? Can I work different hours? Can I work full time but at different times? Can I do some of my work at home instead of having to come in every day? Can I arrange my office equipment so I'm closer to the computer or closer to the printer or phone, so I'm not exerting any more energy? Can I have my workstation closer to the bathroom, or can I have a computer glare, a screen for a computer for glare? Do I need to take more frequent breaks? Can I have headphones to help reduce distractions? So it's real important that you do talk to your supervisor for, some help when you are returning to the workplace. And if you are returning to work, one of the biggest websites that we have found was cancerandcareers.org. That tells everything that you need to know about disabilities and returning back to work. Some of the resources that we use are, Cancer Finances, Triage Cancer, the patient advocate networks. Mark Cuban has a foundation where I think he gets some of his medications from a different, I think from Canada. Medicare has assistance for low subsidy people. There's Medicaid, there's extra help through Medicare. So there are a lot of resources available. We use community resources like food outreach, food banks, Department on Aging, different things like that. So, and we're here to provide you guys with as much emotional support as we can. And it is real important that you do talk with, the social worker or, the financial counselors as you're, going through your treatment, or if you've completed your treatment. Because unfortunately, nobody, as Mark said, nobody is immune to this financial toxicity. It affects everybody, and it affects some people more than it does others. But with that, I'm happy to answer any questions, if there are any.
Okay, thank you so much. That was a lot of really good, helpful information. I think next we are going to hear from our billing and reimbursement department, and that is going to be Miss Lori Lewis.
Hi, everyone. Let me know when you can see my screen. My name is Lori Lewis. I am the billing and reimbursement manager here at Washington University at Siteman Cancer Center. We do have a team here of 36 billing and reimbursement staff. I have pre-certification coordinators who help all of our patients get assistance with their chemotherapy prior authorizations with their insurance. We also have insurance specialists that look at every patient's insurance coming in the door to make sure that it's one that we take, that they're not going to have any financial burden because it's an out-of-network plan, We also have coding specialists to make sure claims go out the door correctly so we don't have any issues on the back end and patients getting a bill unnecessarily. And we have reimbursement specialists that look at all of the copay assistance and drug assistance available to our patients when they start treatment. Financial burden of cancer is really a big thing because we see this every day. And according to the NIH, the average cost of cancer care was more than $42,000 during the first year of diagnosis. Some cost in upwards of more than $1 million when you consider surgeries, radiology services, and chemotherapy. There's combined services that we don't even see all the time where we are in the billing department because other things are billed through different areas like BJC. In the US in 2022, around 43% of the working age adult population are inadequately insured. 9% of those have no coverage at all. We see 11% with gaps in coverage, and 23% are underinsured, which doesn't cover all of their services. They may only have coverage that will cover, their preventative care services for the year, or they may have Medicare AB only, which only provides 80% of their coverage. For the remaining 57%, we are seeing an increase in individuals opting for high deductible and high out-of-pocket insurance plans in order to get a lower monthly premium. We see that all the time. Patients, come in and they never expected to have a diagnosis of cancer. And when they're starting out with that insurance plan, they're going to purchase the one that is costing them the least amount of money every single month. And in turn, that causes higher deductibles and higher out-of-pocket for the year. These out-of-pocket costs for an individual can range anywhere from $1,500 to $10,000 for an in-network service, and will have to be met yearly before the plan pays 100% in most instances. In a recent study conducted by the American Cancer Society, 51% of cancer patients and survivors report having incurred medical debt as a result of their cancer care. Some of them being sent to collections and others seeing credit scores negatively impacted by this issue. So what we do here is we, look to help in every way that we can. We have the reimbursement team that is dedicated to screening our patients and their accounts, looking for ways we can assist our patients financially any way we can. Helping patients financially at the start of their treatment can help their overall journey through treatment, and that's what our goal is. Helping to lessen that burden, there are financial assistance programs within WashU and Barnes-Jewish Hospital. Drug assistance programs through the drug manufacturers for the uninsured and underinsured patients. There are drug companies out there, as Julie had said, that offer free drug for those who qualify, and they deliver the medication to the site of care in instances where they're getting IV and injectable drugs. In Julie's case, we also have other programs similar for our oral meds. And again, patients have to qualify usually based on their income. We also screen patients for that copay assistance program, which is similar to the oral meds as well. Most companies have some kind of copay assistance, whether it be for an oral copay card that you can take to your pharmacy, or a copay assistance that we actually monitor here at Siteman Cancer Center for our patients. Copay assistance can offer anywhere from $1,500 to $25,000 per year per medication for those who are commercially insured and have an out-of-pocket responsibility related to that deductible, copay, or coinsurance. And so what we try to do is reach out to these patients that we see are on a medication that will have a program, and we let the patient know and we discuss that with them to see if it's something they would be interested in signing up for. Once they're signed up, we monitor those treatments every single month. Anytime a patient has a responsibility, we file it with the copay program so the patients don't have to. They have enough on their mind to worry about. This is one thing that we try to take from them because it's not something that they need to do. We can do it for them. For the patients that have Medicare where they're underinsured, there are foundation assistance, as Julie had said, where foundations will base it based on diagnosis. So there is entities like Leukemia and Lymphoma Society, Cancer Care Foundation, HealthWell Foundations. We can review patients based on their diagnosis, and they will get a limited number of funds for the year that we can send their claims to as well. And those are things that we review here for our patients after they have started their treatment. We can review within the system to see what medications they're receiving and how we can help them. Assistance resources, there are a lot of them. This doesn't list all of them, and I know Julie had put up some on the screen as well. Patient assistance and reimbursement guide, you can actually go to a website and they'll show you every assistance program on the market per drug. It's actually not in a booklet anymore. It's on the site, so you can type in the drug that you're on and you can see if there's an assistance program somewhere for that medication. PAF Foundation is another one for Medicare patients. NeedyMeds.org, RxAssist.org, those companies will show you what programs are available for the medications that you are currently on. And I missed, so like another page is missing, so I might have to go back. I apologize. I feel like I skipped a page. Maybe I didn't. I apologize. So we have many assistance programs here. We have our whole team that will get with our patients to assist them in any way that we can. And again, this all starts at the start of treatment. It's the best way to, help our patients is if we can get to them at the start of treatment and help them and let them know that there are resources out there for them for assistance, so they don't incur this financial burden during their treatment and even after, years after. The patients will have, debt, and we can help them with some of that. And if anybody has any questions, we're going to have a time at the end of this to go over all of those questions with you. Thank you.
Okay, thank you so much. Our next up, we're going to move into the Q&A session. So I will turn that over to some of our, you should be seeing a Q&A button that should allow you to submit some of your questions. So I definitely encourage you to go ahead and click on that Q&A tab or the green Ask button at the bottom of the video. So first off, I'd like to ask a question for Dr. Fiala. The first question was, how do patients' finances impact their treatment choice?
Well, it would take a long time to try to completely unpack that question. But on the surface level, not having adequate insurance or adequate finances could ultimately mean people don't receive care, or maybe not the care that's recommended. Sometimes it could be that copays tend to be higher for a drug class like an oral medication versus an IV. So the doctor has to switch to the IV medication because that's more appropriate for the patient's finances, even though that's not necessarily what they would recommend if everything else being equal. But research does show that, on a patient level, it also impacts, adherence to medication. Again, if you're taking an oral pill and you're supposed to be taking 2 pills a day, a number of patients, especially those with more limited finances, admit to skipping pills in a way of rationing care. It could also be in less obvious means, where if a patient is given multiple treatment options, because luckily today for many cancers there are not one treatment option, but many, that they're selecting ones that have lower financial burdens, but maybe not be the most optimal one for them based on toxicity, side effects, and quality of life. So, ultimately, finances could be a barrier to care, but even if they're not, it could influence how a person interacts with their care and therefore potentially impact their quality of life and their outcome with their cancer.
Yes, so building on that, Julie, I was wondering if you could speak to what are some of the most common frustrations that you've had your patients voice to you about their financial burdens. Oh, I believe you're muted.
There we go. So some of the biggest concerns that we have, patients will call me or they'll come into my office and just say, I can't afford my medication. It's too expensive. So what do? I can't pay $3,500, a month. Or when I tell them, your copay is going to be, $2,900, they're like, huh? How am I going to pay for it? I have no clue. I can't take that medication. And that's when we try to help them out by going through, the Health Well Foundation, if they have leukemia or lymphoma, going through the Leukemia Lymphoma Society, try to find a medication assistance program for them. And then if all else fails, if we know that they will meet the criteria guidelines or the income guidelines, we'll try to hook them up with, the manufacturer for one of the free medication lists. Unfortunately, for the patients that don't meet that criteria financially, we may have to talk to the doctor, about getting a less expensive drug. But the biggest frustration for me seems to be, how do I get my medication? I can't afford that. And I can't afford to go into any further debt that I'm already in.
Yeah. So Lori, again, building on that sort of question and also addressing a question from the Q&A, do patients have to apply and qualify for assistance every year? Is that part of the process?
Yes, for most assistance programs, they have to be re-enrolled yearly. For the ones that have an income guideline, they have to show that their income is still within that guideline every year. It really depends on the program, but we constantly are looking at these patients. We're re-enrolling them right now. My whole team, that's what they're working on, is re-enrollments for 2023. And so we're keeping those patients that are already currently on the programs as much as we possibly can. It's not something that we really run into often where a patient would disqualify later. So once they're in it, for a lot of the copay programs, they don't even look at their income for copay programs. It's really only for the free drug that they're looking at income. And even then, not all of those programs are reviewing that. So.
Okay, and this is more or less a question for all of us. Do we proactively offer this information to all patients, or is it the patient's responsibility to ask these questions? And the questionnaire asked if there would be less toxicity if the teams were more proactive in providing this information up front.
I will answer my opinion on this. I do feel like that for our facility, I think there needs to be more consistently pre-treatment financial counseling, which we don't have available all the time. So what we're doing is once a patient enters treatment, we're reviewing their accounts through our Epic system. I have work queues built that allows us to see all of the drugs that have programs, and we're consistently reviewing these daily and calling patients to try to catch them that way and discuss these programs with them at that point. I would love to see this happen when the patients are sitting there and treatment is prescribed by their physician, and get them this information at the beginning. So we are looking at that.
Yeah, and so from a provider standpoint, there are many clinical teams that they know that these drugs that they use are very expensive, and they will proactively have patients complete the assistance package whenever they prescribe that drug. But what tends to also happen is things change, especially somebody who's going through their treatment. Finances today might not be what they are 6 months from now. And I'm not a provider, but talking to the providers, many of which say, well, they may check about finances when they start the treatment, but they don't necessarily keep following up every time they see the patient back in clinic. And, if the situation were to change, that's not always readily apparent. And things like, many people will face here in the coming weeks with resetting of deductibles that happens commonly in January. That might not always be apparent to providers that the medication that was costing you a few dollars a month, until now will be considerably higher potentially after your deductible resets. So making sure that we're checking in with patients on a more continuous basis is certainly where we need to be. Now, relying on providers to do that in the complex system that they work on or they work in might be challenging. And like I said, I hate to put the onus on the patients themselves, but that is something that they can make sure that they are addressing with the providers as it comes up, because no one knows their situation better than themselves.
Mm-hmm. And piggybacking off of Mark, one thing that we do is if the patient's been denied their assistance program, we'll appeal it for them. We'll help them go through that appeal process, because I had somebody who's had 2 medications whose copay was $6,000 and they were denied because of their income, but they didn't take into effect that they had 2 medications, that it was going to cost them $6,000 a month. So it is a process where, you do have to get a letter of necessity, and, the doctor may have to write a letter, but we appeal as much as we can. And a lot of times, we'll put on there, we're no longer working. Our income is no longer the same as it was last year. And a lot of times the insurance or the manufacturers will, look at that after we appeal the process and, really explain to them what's going on with the families.
Okay, we have another question. Since up until now, we've been talking about a lot of the patients who are currently engaged in their treatment and seeing their physicians. Are there any available resources for individuals once treatment is ended? Because we know that getting out of debt can be really challenging.
So I will speak to one thing. If a patient has any kind of debt, they can call, and have it reviewed, because some of even the copay programs will retro cover. So we can get retro covered claims up to a year on some of those programs that the patient's already even paid for. So even if they've made payments on those claims, if we can get them covered by the copay company, we can reimburse the patient what they already paid, some programs up to a year prior. So it really depends on what the need is. And what their debt is. And, if they can't get any of the assistance that way, then we're going to review to see what else is available to them or get to them to the place that they need to be for that assistance, whether it be, payment plans, any kind of assistance that's out there for them. We're going to try to get them, to the correct place.
So in terms of, sort of how to initiate these conversations as a patient, there are 2 questions that have come up in the chat. Does every patient have access to a social worker, or is there a review method in place? And second, are there navigators or community health workers? Are those typically part of this resource to help bring people to these resources and these services?
Yeah, for social work services, you don't need a doctor's referral. We have a social worker at every satellite office and also at the CAM building. So, each social worker is responsible for their individual clinic. We're available, regular business hours, 8 to 4:30. I keep my door open. So if there's a patient that comes in and has a question, if my door's open, come on in, and I sit down, tell me what's going on, we try to come up with some community resources. Some of it may be, if they just may need some emotional support, some may need some assistance at home. So we may make a referral to, for homemaker services. We may make a referral to food outreach, if they're currently receiving treatment. We may give them some suggestions, gas cards. We get money and grants from the American Cancer Society for some gas cards. So when we have those available, we're able to reach out and have them come in. And they're welcome anytime by either calling. Every new patient gets a folder, and our business cards are in that folder with the doctor's names, the nurse coordinator. And so they're welcome to call us at any time, and they don't need a referral.
So certainly services are going to vary from institution to institution. Many institutions in recent years have tried like financial navigator programs, and studies that included those have shown promising results. The issue is really, it becomes almost unsustainable, especially for sites with the volume like Siteman does, of trying to see every patient, every visit, or even every other visit. We would have to employ hundreds of Julies just to make that even feasible. And that's really been the issue. And considering most of those services are not currently paid for by insurance, or by providers like Medicare. And that's really been the issue to date, is trying to make sure that providers like Medicare are required to pay for those services, so that they can be offered. Because right now the hospital provides those services to patients, and they're not necessarily reimbursed. And that really becomes the issue, is just how can you sustain that kind of program in an institution? You're on mute, Sarah.
Oh, sorry. And yes, and that's a good segue into the next question, which is, based on your research, are there any recommendations that you would put out to the hospitals in terms of the organization and how to reduce the patients and the survivors' risk for financial burden?
So on an institutional level, it becomes difficult to try to reduce somebody's risk because every person's different. What I think we can do a lot better at is assessing patients longitudinally. As I said, many providers say that they will check with financial services or check copays after they prescribe a new treatment, and ask their patient, well, how much is your copay? But that might not be something that they're doing on a regular basis. So implementing screening tools to try to figure out what patients could use a referral to social work, or financial services like Lori, would be a potential improvement. So there are several questionnaires that are used mostly in research purposes to try to screen patients and figure out what patients are at the most need. And there's now research looking at trying to implement those into regular care. When you come see a provider, you're asked many questions, and sometimes you're even doing questionnaires with the MA. You're doing distress screenings. Having a financial distress screening in that as well would be a way to potentially screen patients and make sure that while we don't have the resources to send every patient to Julie, that we're identifying the people who could use that the most, and making sure that referral is made if warranted and the patient wants it.
And so during that screening process of identifying the patients who may be in need of these services, Julie, I was wondering if you could speak to what types of emotional support that your department can provide to patients who are impacted or sort of bracing themselves for the potential financial burdens.
Sure. One of the things that, we definitely, I know for myself, I have most of the social workers, do have their clinical social work license. So we can sit down and do, some informal counseling with patients, just to let them know that, they're not alone, validate some of the feelings, the frustrations that they're having. But we also make a lot of our referrals to the, psychology services, to the mental health providers. If somebody has insurance, most insurance companies now, take social work, clinical social workers, licensed counselors. They take their insurance and they may only have, a $10, $20 copay. So we make a lot of referrals to outside resources when we can't, if it's going to be a little bit more than a couple sessions, then we make referrals outside. But, we connect them with support groups, if there's any available. Just really we're there to help them navigate not just the financial aspect, but definitely the emotional aspect, because it takes a toll on not just them, but also on their family. When they've been given this diagnosis and now all of a sudden their world, it's been turned upside down and they don't know how to navigate that. So we help them navigate it. We give them the tools that they need. There's different websites that we use, different techniques that each of the social workers, everybody has their own strength, where we, can use relaxation exercises, deep breathing techniques, there's tons of different things on the phone apps, that you can get now, for free, that will help you, just kind of calm down a little bit. And so we do a lot of that. We help them make decisions, about their care, if they're really struggling or if they think that they're going to be hitting closer to the end of life. We talk about that with them. And, obviously finances sometimes does play a big role in that, because they don't want to, be spending all their hard-earned money, on cancer treatment, where they'd rather, live the next 6 months or 8 months or, the next year just with some quality. So we do talk with them, about finances and end of life and where do we go from there? How can we give you quality versus quantity at times? But we help them make decisions about that. And then we talk to them, about hospice care, homemaker services, just how to get back into the community and how to, go from feeling so sick and not knowing what to do to starting to feel better. And okay, I feel better. Now I feel guilty because I'm smiling or I'm laughing. And so we do a lot of validation, and help them with their feelings.
Thank you very much. So I think now we're hoping to transition to our post-test. We're hoping that we've provided everyone on the webinar today with some helpful information. So you should be seeing a post-test screen that will pop up on your screen here. And you should be able to click on this QR code to begin the survey. And we really appreciate your help. This information helps us to decide what topics are of most interest and what we can do to be the most helpful to answer the questions that exist among our patients and their families.
What was that? Sorry, you broke up.
Okay, thank you everyone who's working on the surveys now. And if you could stick around right after we close this survey for a brief questionnaire, just to ask about sort of what topics are interesting to you for the upcoming webinars. Our next webinar will be Survivorship Series number 4. So be on the lookout for information regarding that presentation coming up soon. And today, I'd just like to thank everyone here on the call today, Dr. Fiala, Julie, and Lori, for their time and for all of the information that they're providing. We hope that this information was helpful to all of the patients and families on the call. And we are definitely interested in learning more about what information and what resources are going to be the most helpful for everyone during their cancer journeys. After the webinar today, we will be sharing the materials that were used during the webinar. So be on the lookout for those coming up here soon.